Hi, thank you for joining us here at the Colorectal Cancer Alliance in Washington, D.C. I think maybe we'll take a couple of minutes to wait for a few more people to join, and then we'll start with our webinar and conversation with Dr. Marshall. Was watching. Can they? So hi everybody again. This is Ronit Yarden, the Director of Medical Affairs here at the Colorectal Cancer Alliance in DC. And I'm here with Professor John Marshall, who is a medical oncologist and from MedStar Georgetown University and the Lombardi Comprehensive Cancer Center. And he is the Chief of Hematology and Oncology Division and the Director of the Rouse Center for the Cure for Gastrointestinal Cancer. So thank you, Dr. Marshall, for being here tonight with us and was willing to pass on information to our community that was shared at the last meeting of the American Association Society of Clinical Oncology, ASCO GI, that is dedicated for gastroenterology cancers. And our community is always eager to learn more about new development and breakthrough. So I hope you can share with us some of what you learned last week.
I'd be pleased to, Ronit. Thank you very much. I'm glad a few people have logged on, and the way I think about it is you've got a doctor for 1 hour with no copay, so maybe that'll go okay for the folks. But if you'll let me, I thought I would kind of give some perspective to our audience about what exactly this meeting is for, and we think of it as a big cancer meeting. It is. It's not the biggest cancer meeting. The biggest one is Big ASCO. So the American Society of Clinical Oncology has an annual meeting in June, end of May and June in Chicago. Not a great place to be tonight, I think. But and there are about 30 or 40,000 people who go to that meeting. And it's very scientifically oriented. And I will have to say that most of the new data that is presented is kind of saved for that meeting. And it's almost too big. The meeting is so big there that you can't see anything because there's too much data being presented. But there's a certain paparazzi-ness, if you will, for presenting data at such a big meeting. And so the subspecialty groups, the GI cancer group, the breast group, the lung group, created or started their own meetings, which were much more multidisciplinary. The big ASCO meeting is really for hematologists and oncologists. The GI ASCO meeting is in collaboration with the radiation oncologists and surgeons and the like, and it's meant to be a much more multidisciplinary meeting. And it serves sort of two purposes. One, is to present new data that people bring forward for that meeting, very specifically for that meeting. But it also is a really fabulous moment for education. There's a lot of reviews and synthesis of what's going on. So it's a 3-day meeting. It's in San Francisco all the time. We actually had a little bitty earthquake while we were out there. It was exciting. So we presented some data. Lots of us presented some data. There was some new evidence out there. But I have to tell you, the reason I go to this meeting every year, and it's now in its 11th or 12th year, is it's a great chance for us to get together and discuss the data that's happened from the year before and sort of help steer how we're going to go forward. So there's not a lot of new evidence to present. We'll talk about what the most important stuff is. But it also, we start the new year with a very solid footing of the advances we made from the last year to move forward.
So that is great. So I wanted to start first was we hear a lot about in the news about biomarkers and biomarkers for colorectal cancer. And I wonder if you can start explaining what are biomarkers and which ones are important for colorectal cancer patients, and are there any new developments in the field of biomarkers?
Yeah, that's a great question, and it is probably one of the most important things that we've got going on in GI cancer today. So the concept of a biomarker is, instead of just making my best guess as a doctor and saying, all right, I'm going to give you this treatment or that treatment and see how it works. What we would have is some test, some ability to say that for this patient in front of me, that this treatment would work better than that treatment. Or even more importantly, in some cases, let's say for stage 2 or stage 3 colon cancer, we give everyone or many of these people chemotherapy. Most of them don't need it. And so could we figure out the group of patients that don't actually need the chemo, and we can tell them that they're okay? But so we're looking for anything to try and guide us away from just guessing. And so that's basically what biomarkers are. Now, they're big picture biomarkers. Yes, you have cancer. No, you don't have cancer. But then there are also biomarkers of certain medicines. So, for example, we know that certain kinds of colon cancer drugs only work if you have the right biomarker, if your cancer has the right gene test on it. So there were a couple of abstracts that I think were pretty important at the meeting. And they really are looking at more, one is around tumor characteristics. Can I look at something on the cancer itself? And the other was in the blood. Can I find something in the blood that would tell me one way or the other about how the cancer is going? And I would have to say the most exciting new breakthrough in colon cancer that's not quite broken through, but it's going to happen fairly quickly, I think, is this idea that after you've had your surgery, to do a blood test to say yes or no, there are still genes or still cancer cells in the blood. And so the more we are looking at that, the more we are finding that that's going to be useful. So it's not standard yet. And I think our audience really needs to know that there isn't a standard test that you can just go and send, or that insurance will cover, importantly, at this point. But there are many of the meetings we had at the symposium were in fact focused on designing the clinical trials to be done quickly enough so that we could be sure, we want to be sure that the test is correct. Because if we do the test and it's sort of okay, it doesn't do us much good. So we really have to have a level of certainty. So that was one of the abstracts, is around stuff in the blood. The other abstract, as you know, was one about the tumor. And a very, very smart team led by a guy named Galon, Galon, presented their data around what's called an immunoscore. Now, bear with me a second. So cancers have new genes in it. They're cancers because their genes are broken. And those broken genes can be seen by the immune system as foreign. And our immune systems are designed to get rid of foreign things, right? Sort of like that wall that the president's going to build. So get rid of things that are foreign, right? So, but what happens is that if the immune system can't get to the cancer, then the cancer grows. And so what this group showed was that when the colon cancer has an immune response going on against it, so when they do the surgery and they look at it under the microscope, they can actually see the immune cells that are coming in to get it. And they use that to develop what's called an immunoscore. And you either have this immune infiltrate, we call it, or you don't. If you have the immune infiltrate, it means your immune system is awoken against your cancer and your prognosis is much better, because the theory being that if it can see the cancer there in the colon, it's seeing any cells that might have flown around there. So they presented a really cool picture. It's a biomarker of looking at the cancer itself to determine if it has an immune infiltrate or not, and the prediction for positive outcome was there if you did. Cool stuff. Again, not ready for prime time. This is a French group. The French group has now got a lab in the United States. It's in Richmond. We at Georgetown are collaborating with them on a project. They're trying to collect more data so that, just like in the blood test, we can use this tumor test to decide who needs chemo and who doesn't. So pretty exciting stuff.
Still talking. Oh, great. So, so the immunoscore, would the immunoscore be eventually developed in a way that the doctors can decide who should get therapy and who should not?
That's the whole idea. Is particularly in stage 2 and stage 3 patients, where we give way too much chemo, because as I said, most of the patients don't really need it, but they feel like they have to take it because they don't know if they need it or not. And you'd feel silly if you missed it, if you didn't. So a test like this would make it much, much better for our patients, because we could not, we need to predict who will and who will not, and this will help. Yes. It's the whole idea.
So cases where there that maybe were discussed in the meetings?
I'm sorry, you're breaking up a little bit, probably my Wi-Fi, but are you getting me okay? Okay. Yeah, there's other pretty interesting stuff that was presented. The most hot area of research right now in all of cancer is around immune therapy. And how do we use this relatively new breakthrough to treat colon cancer and colorectal cancer? And I think most of our audience probably knows, but at least for immune therapy, there's a group that have a problem with their tumor called microsatellite instability, or MSI high. Now, it's only a few percentage points of patients who have it. And if you have that in your cancer, if that's your colon cancer gene problem, then the immune system is very effective, and these new immune therapy drugs are very effective. So everyone who has colon cancer should know whether they're MSI high or not. And so if you don't know, ask your doctor. You should know, no matter what stage you are. But as I said, that's rare. So the majority of patients don't have that. And we keep trying these new immune therapy approaches to see if we can make them work in colon cancer. Now, in the microsatellite stable, or MSS colon cancer. Now, The most disappointing study I saw at the meeting was an abstract that looked at using a vaccine after surgery. And the vaccine, it was not just any surgery, it was surgery after patients had their liver metastases removed. Now, many of you out there may know that in colon cancer, we do sometimes cure patients with metastatic disease by operating on them and removing the mets. Basically, as I say, weeding the garden. But these patients who have those mets removed are still at very high risk of having more weeds in the yard. And what we don't know yet is how best to treat these patients. So in this clinical trial, half the patients just got surgery and the other half got this vaccine afterwards. And admittedly, it's not, who knows whether the problem was the vaccine or what, but it didn't work. And in fact, not only did it not work, it was a little worse if you got the vaccine versus if we just left you alone and just did the surgery only. Now, this is in distinction to a study I got to participate in a few years ago with the gang down at Duke, a good friend, Mike Morse. And we did exactly the same study with a different vaccine and actually showed it helped. And so this was in contrast to that. So I was disappointed that this study, in fact, showed negative results. It's the perfect group to study, but maybe this is not the right drug. The second immune therapy study that I thought was worth reporting was incredibly controversial. So I told you that the MSS patients, the new drugs don't really work. Well, this group did what's called a phase 2 study. It's a smaller study, but half the patients got nothing, placebo, and the other half got 2 immune therapy drugs. Now, these were patients with metastatic colon cancer, our people, right? It's our community. And they all agreed. They knew that they might be getting placebo. They knew that they might be getting the real medicines. And they went in, and the patients who got the 2 immune therapies did a little bit better, not statistically better, but a little better. And the reason this is so important and actually risky, if you will, is that everybody wants immunotherapy. All of our patients are knocking on our door and saying, why can't I have immune therapy? And the answer is that so far in most colorectal cancer patients, it hasn't worked. And so this study saying a little bit of benefit is going to make people tempted to ask for these medicines. They cost $45,000 a month, and they only helped a few people a little. And the reason this is not the right thing to do is that when immune therapy works, it really works. Okay, so people do very well for a long time. That's why people want it so much. And so the temptation is going to be, oh, just let's try it. And in point of fact, I'm not sure that is the right answer for our patients. So the immune therapy story from ASCO GI was disappointment more than any positive new evidence. So I'm sorry to report.
So, were there any clinical trials that are trying to, new clinical trials that are combining maybe immune therapy with?
Well, that's more or less what I was just talking about. There's certainly clinical trials of immune therapy plus chemo. One of the nice things about this meeting is that we present what's called trials in progress. It's a little bit of a marketing thing to say, look, we've got these studies open. We are looking for patients. So no question, we haven't given up on immune therapy in colorectal cancer patients. Quite the opposite. But we're disappointed that we haven't found the right cocktail yet.
Were there any other trials that were presented at the meeting that did a combination of therapies that were successful?
Yeah, I think probably the most important other arena where new data has come forward is in rectal cancers. So we know that rectal cancers are a more challenging disease often, really because of their location. Many people with rectal cancers have to have ostomies. It's life-changing. And I know our crowd on the call tonight knows that very well. And so a lot of our work is trying to keep curing people with rectal cancer, but reducing the treatment that's required to do that. So right now, we typically use chemo, radiation, and surgery to treat rectal cancer. And it's interesting to watch this happen over the last 5-6 years. It's funny because everyone's trying to put the other one out of business. So the radiation and the chemo guys are trying to put the surgeons out of business. The surgeons are trying to put the radiation people out of business, to try all of that in good to reduce the long-term consequences of curing patients, the process of curing patients. So one of the interesting studies, most of us have been using radiation for rectal cancer for a long, long time. And there is some evidence, two real important studies here. One study looked at what we call short course radiation. The standard radiation is 5 to 6 weeks, every day, Monday through Friday, and you get sores and it hurts after a while and you hate it after a while. But it does shrink the tumor very nicely, and has been the standard for a long, long time. The Europeans approached this a little differently by using what they called short course radiation, 5 days, 1 week of radiation. And the more we have looked at short course radiation, we're seeing that it actually meets the same basic goals: less expensive, less time for the patients, less side effects. And so we are seeing more and more data, and we saw more data at this meeting to support that short course radiation. The other piece that's come forward is this idea that you don't actually have to operate on every patient. We know that when you give chemo and radiation first to rectal cancer and then do surgery, and the pathologist looks through to look for any cancer left or how much cancer is left, about 20 to 25% of those patients, the pathologist won't find any cancer. And we call that a pathologic complete response. And we both love it because it's good news, but the reality is that patient didn't need the surgery they just had. And so there are some who are doing what we call watch and wait, where they do the chemo radiation, everybody looks around with a scope and with a scan, and they don't see any evidence of cancer. And instead of just proceeding on with surgery, which is what the normal pathway is, they say, well, let's just be we'll keep a very close eye, and maybe, just maybe, you're one of those 20, 25%, and we'll never end up doing surgery. But if your cancer regrows, then we have to go right away to surgery. So that's the strategy of sitting on it, and no pun intended there, and waiting to see if it comes back or not. I have to tell you, that makes me so nervous. I hate watching these folks. I mean, I understand why they want to save their tail, but at the same time, we have to remember that's only 20, 25% of patients where that happens. And so I get very nervous. But there are some that choose to do that, where particularly in patients where their tumors were very low down and they were going to have to have an ostomy for the rest of their lives. And they think that's probably worth, the risk, if you will, to see if they're one of the ones. Along with that, we do know that after you've gotten your radiation, if you will, the longer you wait, there's more and more shrinkage. So radiation, while it finishes after a month or so, the impact of that radiation carries on longer after the radiation stops. So there was a study looking at surgery right away versus waiting till later. And to me, the punchline of that study was there wasn't really any difference. There wasn't an added advantage of waiting longer for more response. But what's happening is a lot of people are doing their chemo radiation first, then giving the chemotherapy, and only in the end doing the surgery, so that the ostomy can be reversed more quickly. So we are seeing a shift from what we call a sandwich, some before surgery, some after, to now everything is being done before the surgery. And the nice thing about that for patients is it shortens the time that their ostomy, that they have to have a temporary ostomy, and those people who can be hooked back up. So I think all of that data in rectal cancer is very important, and was presented nicely in the group. So those are the main clinical trials in colorectal cancer that I thought were important to share.
So touching on this rectal cancer data that was shared during the meeting, it looks like there is, for a patient who might qualify, there is this question is like whether you want to be safe or whether you want your quality of life to be better.
This is it's a hard discussion. It's a long discussion with patients.
That is a discussion that a patient may need to take with their personal physician to when they looking how to approach their forward.
But I'll tell you that all we do is colorectal cancer, so we're very familiar with this. Most oncologists are general oncologists, and I have to say that the comfort level with these different approaches is variable, right? Some groups are early adopters and just jump right in and try something a new way. But I have to say most folks still follow the guidelines that are out there, and the guidelines give us some variable options, but there are a lot of teams that aren't comfortable for that. So I'm not necessarily I'm hoping we're arming the team to know what's out there. But sometimes the team that's taking care of you is not comfortable doing that. And sometimes that's where they are with it, or they've made some judgment in your case. So, and remember, it's a team, right? So you have to have a radiation oncologist, a surgeon, and the medical oncologist to all be in agreement with how they're approaching this. That being said, it is not uncommon for a patient to want something different than we want. They're informed, they have made a judgment, they've done their research. And I have to say, we unless they're totally crazy, we go along with it, if you will, and say, okay, as long as you know what your risks and benefits are, and as long as you feel like you're adequately informed, we'll go forward with it, even though it might not be the current standard.
Yeah. Well, we have several questions from the audience here, so let me read them to you. So this is going back to biomarkers, and could the blood test be used to tell if your cancer is progressing or stable or responding to treatment in people who are non-CEA response expressive?
So that's a very good question. There is some evidence, yes, that something called circulating DNA and circulating cancer cells can be used to detect that. The problem is that those tests are very expensive. A CEA is an inexpensive test. Those blood tests are very expensive, and they're not highly established. So I don't think we've got today a very strong test that you could use to, for example, measure at your first few doses of chemo and say, oh, this is working, we should keep going, or no, this is not, we should stop. So we're not quite there yet, but it is where a lot of the research is headed, because we don't want to expose patients to medicines that are not helping. We want to minimize that side effect and cost. But we have to remember in colon cancer that something called stable disease is valuable. And so maybe the marker doesn't change, but it stays stable. I wouldn't want to abandon that treatment until I saw that a scan showed that it was getting worse or something like that. So good question. There is research going on in that space. but I don't think there is some test that's better than others for that at the moment. One thing that kind of goes along with that is I think everybody knows who has metastatic colon cancer about RAS mutations, RAS. And we can detect those mutations in the blood. And so some patients don't have a RAS mutation when you test their tumors, but over time they might develop one. So we learned this lesson from our lung cancer friends where they monitor patients with mutations using blood tests. And so we're beginning to see some of that in colorectal cancer.
So another question that came out is like, instead of attacking receptors one at a time, can we attack them at the same time, several of them? And I think that was recent use and with 3 different drugs that are attacking 3 different receptors. So if you have anything to say about that.
So which receptors are we, just so I make sure we're talking about the same thing?
Actually, the question doesn't list receptors, but I think the new drug, the 3 combinations were on 3 different proteins.
Oh, I know, I may know what they're referring to. And this is the BRAF targeting.
BRAF, right?
Yeah. So that's now established, right? So based on a fairly small trial, colorectal cancer patients that had a BRAF, a very specific one, V600E mutation, which is a mutation that's also found in melanoma, skin cancers. Only about 9% of colon cancers have this mutation. That's important, so it's not common. But if you throw 3 medicines at it, a drug that targets BRAF, one, an EGFR drug, and a MEK drug all together, we are seeing increased response rates. So it's not like we're curing these people, but what is happening is that this BRAF mutation is associated with bad tumors. They grow faster. And so we now have some specific medicines which can be given to patients with this. So just like we talked about MSI, you have to know that. All colon cancer patients with stage 4 disease have to know their BRAF status. And depending on that level, it might change our treatment choices.
So does every patient get to be tested for RAS and BRAF?
And MSI and HER2.
So that is standard of care?
Yeah, it is. And every patient should know it. So let's do the parallel to the empire of breast cancer. Every woman with breast cancer knows ER/PR and HER2. They all know it, or are they triple negative? And actually, I bet many of us know it because we're so familiar with it. We need to do the same thing in colon cancer with one additional finding. So RAS, you need to know that, BRAF, MSI, HER2, and believe it or not, you need to know where the cancer started, right-sided versus left-sided. We know that left-sided tumors tend to be better and tend to respond better to some of our treatments. And right-sided tumors tend to be more resistant and less responsive. So all of those factors need to go into all of our decision-making. Part of our problem in colon cancer, colorectal cancer, has been really not studying right-sided colon cancers differently from left-sided. They really are 2 different diseases the more we look. And we don't know why. We don't really know why. And so currently more and more we are designing trials where we know prospectively right side versus left side so we can learn some important lessons that I know are ahead of us.
Another question I got here is, if diagnosed with rectal cancer and did daily capecitabine and radiation and didn't have a surgery, can you be sure cancer is gone by scoping, biopsies, or blood work?
No. time will tell. But you could be completely negative on a colonoscopy, for example, on a CAT scan and a CEA, and there still could be some alive nests of cells there that will regrow. Think of it as, you're pulling weeds in the yard, and sometimes you get that thing all the way by the root, and there's nothing left in there. And sometimes that you snap that root off. So you don't see anything when you look in your yard, but you know that there's a root down there. And the only way to know for sure is wait around and see if it grows back, or get a shovel out and dig that root out and find out was there really something there or not. And so that's where people are right now. We don't have a perfect test to say that for sure.
So another question here is, do mets in the right side tumors respond less in the same way that the original colon tumor might?
Yeah, so that's what I mean by that. So it's actually, a lot of patients don't know which side their colon cancer was on. If you ask them, you can coach them through. But we are talking about right-sided colon cancers that have been removed, but now let's say it's spread to the liver or the lungs. They behave like right-sided colon cancers. That's what I mean. It's kind of a different disease. And we don't, as I said, we don't really understand why. So it's important to know whether you're right-sided or left-sided.
Another question here from a patient is, she was diagnosed in 2010 with triple negative breast cancer.
And she knows about her markers. They're all negative.
And then diagnosed with rectal cancer in 2018. Is there a connection?
Well, it can be. So nowadays we are testing everybody for genetic inherited syndromes. So generally we don't think of breast cancer and colon cancer running in the same cancer families. Breast cancer is more ovarian and uterine and stomach, and colon cancer is generally a different profile as well. So, but I think anybody who's had two cancers deserves having at least their tumor tested for these genes to see if there is something running in the family. There's an interesting connection between estrogen and colon cancers. So we did some looking at big databases. One of the things that we discussed in San Francisco was looking at gender differences for colon cancer. And what was seen is that premenopausal women may in fact do better with their cancers than postmenopausal. And so there's some suggestion that this might be an estrogen effect. And if you know your breast cancer story, they don't want any estrogen, right? They're really nervous about anybody taking any estrogen even. Whereas if you look at the colon cancer literature, estrogen might actually help prevent colon cancers. So this is not to tell everybody to run out and pop a bunch of estrogen. But when you look at somebody who had breast cancer and then we shut down their estrogen, maybe there might be an increased risk. So we also have to remember that both cancers are common, okay? And so it could be that you just, having a bad day when you get two cancers in one lifetime, but they're just common. So the answer could be maybe there's a connection, but maybe it's just random, and because they're both common, you got two of them.
Okay, another question here is, do you have a better test for signet ring cell scans? Would you treat it with CA rising when CA is rising?
So I would need to know more detail. So signet ring by itself usually is a more aggressive cancer, not always.
So if they're negative, does it have an
if you don't have signet rings, I know a lot of patients fix on this, and pathologists do, and we generally associate it with a worse prognosis. but I can tell you how many patients I've got with signet ring cancers who live many years with their cancer. So I don't think it's an absolute predictor of whether your cancer will be nicer or meaner. But rising CEAs are an issue by themselves. So patients who are just in follow-up and they go to their doc and they get their CEA level and it goes higher. And I'm not talking about going from 2 to 3. I'm talking about going to 10 or 12 or higher. Well, we're pretty worried in that case that there's some cancer around, and you can do scans and look, and a lot of times you don't find anything, whether it's a PET scan, an MRI, a CT scan, anything you want to do. And so there's always the temptation to say, well, we're just going to give you chemo. And honestly, I would not. I would keep an eye on that. And it's a very anxious time while you're watching a CEA rise. But we have to remember that the only known way to cure colon cancer today is to cut it out. And so if a patient's CEA is rising, honestly, the right thing to do is wait and see if one weed shows up. And if the one weed shows up, you could fix it. If multiple weeds show up, you weren't going to be able to fix it anyway. And so that's the problem with doing cancer markers sometimes, is that they create anxiety without a solution. But it doesn't mean we don't do them, but it's one of the side effects, if you will, of doing cancer markers. I hope that answers the question.
Yeah. So I think one interesting thing that was presented in the meeting was that one of the most important genes that is mutated in colorectal cancer, called APC, when it's mutated, it's activating a whole signaling pathway or chain of events that make the cells grow better. And it was presented in the meeting that maybe that is one of the causes that prevents from immunotherapy working with MSS tumors. Do you think there will be any follow through on this approach, as trying to combine maybe APC blocker or any inhibitors of APC pathway with immunotherapy?
Well, I don't know of such a blocker or an inhibitor, and we do know that APC mutations are very, very common across a bunch of colon cancers. The attempt to classify patients' colon cancers into the different categories is ongoing work, and I do think we do know that APC is a fundamental mutation for polyps, if you will. And so the patients who have polyp-based cancers, APC is going to be important. There's also a molecular categorization called the consensus molecular subtypes, CMS. And this is looking at not just one gene, but actually a series of, in this case, RNA, so not DNA, but RNA. And these very smart people categorized colon cancer into 4 categories, one of which was an immune category, but others were an APC category, for example. So I do think, yes, that where the field is going is broad gene testing and using these multiple abnormalities that we find to predict outcome, to predict therapy choices. And as long as we're treating all colorectal cancer as one disease, we're not going to succeed as well. We have to sort it into its different molecular subgroups, and we have to analyze patients that way. That's why I feel very strongly that all patients should have these gene tests. That's why I feel strongly that the Colorectal Cancer Alliance, one of our best meetings was with you guys about how we're going to work together to really drive this science, to insist on this science, because that's important. And we're not all the same. Not every patient with colorectal cancer is the same. And right now, I, as an oncologist, don't have the tools to when I first meet a patient to tell you how you're going to do. I have to wait and see. And so the APC paper that you referred to, I actually didn't see the presentation, but I did hear about it. I think is an important step in that way of thinking about the different kind of cancers. If we think about breast cancer, they have separate sessions for triple negative, for ER positive, et cetera, HER2 positive. It's separate meetings, separate rooms, right? Because they recognized early on that these are different cancers with different fundamental principles. And so maybe that's where we ought to go with GI ASCO, is divide up on colorectal cancer day into separate rooms instead of all being in the same room.
Another question here is, are there any new treatments on the horizon for patients with many lung mets in all quadrants?
Yeah, I think lung metastases are their own thing. Many patients with typically small lung metastases, they grow very slowly. They can be very quiet and asymptomatic for a long time. When we look at the anti-angiogenic drugs, so this is bevacizumab or Avastin or regorafenib, Stivarga, these kinds of drugs often do work a little better on lung, in my opinion. They don't change size very much, but what you'll notice on scans is that they become hollow. They kind of hollow out from the treatment. But it's a very good question. We have been beginning to look at metastatic patterns as well, as a way to help distinguish and predict. But we kind of all know it. If you're an old doctor like me and you've been around the block a while, you know that pattern because you've seen it. But we don't know why. And that's really where the work comes forward, is to figure out why. Let me share with our audience one of our big barriers that we are all trying to work together to solve, is that many of you, when you go to the doctor, the doctor spends most of their time typing in your answers to their questions and entering into databases. Those databases are actually quite valuable to scientists. But our problem is that we don't have good, safe ways to share that data, because you all know about HIPAA and privacy. And one healthcare system's not really supposed to share their data without permission with another healthcare system. And so we have these silos of data. And a lot of what we're trying to do is lower those silos, merge those silos. And again, that's one of the great things about this group, is that that's really one of their goals, is to data collect collaboratively. And there is, if you Joe Biden's moonshot is all about collaborative data. So if you have influence, if you want to help the cause, it's not only participate in these data sharing agreements when asked. The doctors often will ask if you're willing to share the data. It's anonymous anyway, so most of us, Google knows everything about us anyway, so what the hell. But also to apply pressure to your government people to say, this is important, and if we're really going to cure these cancers, we need data sharing will be critical.
So clinical trials are also a very important mechanism for developing new and innovative drugs and finding new treatment regimens. What can you tell us about some of the outcomes, some of how that is in the pipeline, or how can people actually enroll in those clinical trials?
Yeah, there's some part of our problem in colorectal cancer is we have more patients than trials right now, which is bad. So we are doing a lot of studies. Studies are different now. So it used to be that anybody with colon cancer could go on the study. And half the people got treatment A and half the people got treatment B. But as I just told you, we now know that there's different kinds of colon cancer. So now the BRAF patients are going to go on this study. The MSI patients are going to go on this study. The others are going to go. So because each one of these studies has very specific criteria, you have to be the right match at the right time for that study. And even though we at our center might have 20 different studies open for colon cancer patients at any one time, the actual match where patient in front of me right now is eligible for that study right now and wants to go on that study is more challenging. So and so there's a lot of good stuff going on. Combination immune therapy data, as you talked about, combination targeted therapies, combinations of things with traditional chemotherapy. So there are a bunch of studies that are going on, but you have to be sort of at the right place at the right time. And even in our center, where that's one of our lifeblood, goals is to participate, offer, and follow patients on clinical trials, on the best trials we can find, and write ourselves. It's still a challenge. So, and a patient who's looking around for a trial, that's really a challenge, because the websites, as you know, are not great. They're not up to date as much as they could be. They try, but it's hard. And you have to go and be seen by somebody, and you don't always have the time to do that. So it is a challenge. What I will tell you is that to me, the hottest thing that's kind of emerging, and my fingers are very much crossed on this, a lot of colorectal cancer patients have a RAS mutation. And we have long thought that there was no way to make a drug that would actually fix this gene that's broken, or to undo the switch, if you will, to block that pathway. But this year, I think there are 3 new medicines in trial just in the last few months. And I am very hopeful. There's a lot of stuff among my patients who are watching your all's chat rooms and others. And if these medicines will work for RAS mutated colon cancers, we will know it fast, and they will make it widely available fast. So we won't have to wait long. And so I am hoping that the end of 2019 and next GI ASCO, that we have a different message, one of a major breakthrough around RAS. That would make me very happy.
Where one can find information about those new potential RAS inhibitors or treat.
Where everybody else finds out things, go on Twitter. I mean, they're open in a few centers. They're starting with early phase designs. I will tell you all, there are long waiting lists because these studies are small and new. But my hope is that within a fairly short window, we'll see enough benefit that it'll support a rapid expansion. So that's what we're hoping to see over the next few months. Fingers crossed.
Well, that's a great place to kind of sum it up. Thank you so much, Dr. Marshall, for being here today and providing all this exciting and important information for our patients. And thank you, everybody who joined the call to learn about exciting new news from ASCO GI. And for more information and resources, you can check always our website of the Colorectal Cancer Alliance, the ccaalliance.org. And that's it for tonight.
Good night, everybody.
Good night.